Thank you, Cécile, and thank you for the invitation. Thank you, Gregory. So just a quick word of introduction. So the European Brain Council, we are Brussels-based non-profit organization promoting brain research, brain innovation, brain health, and emerging notions like the brain capital or brain-based economy. Here in Brussels, towards EU institutions, our membership revolves around patient organizations with the umbrella federations of people living with a neurological disorder, EFNA, as well as the Federation of People with a Mental Disease, GAMI in Europe, together with also clinical, scientific, and professional societies, the private sector, and a network of national brain councils. And we have proud representative of the Belgian Brain Council today in the room. But it's a network now across Europe, building this agenda and building one voice and building the consensus around the priority needs for advancing research into the brain at the European level. But for the topic of today, maybe a reflection about the agenda around the emergence of brain health, because it's now, let's say, an umbrella term being pushed really by the WHO very lately with global action plans on dementia, mental health, and no epilepsy and neurological disorders, where we see that is really capturing the essence there. We see it really as an opportunity now to push the development of national strategies and obviously build a European coordination strategy around the needs for brain health. So what we have done in that context and the level of interventions, it revolves into this notion of biopsychosocial approach that Gregory, you basically explained. It has been translated in many of our projects on the value of treatment for brain disorders in Europe. So it's basically trying to capture what was the benefit of improving outcomes for people living with a brain disorder in many different disease areas. So we actually conducted this analysis of the care pathway. So it led us to start a new series of projects around the rethinking of the management of brain disorders. Lately, we produced a paper on rethinking Alzheimer's disease. It was presented in the European Parliament earlier this week. Obviously emphasizing those level of interventions, pharmacological, neuromodulatory, but also non-pharmacological, obviously. Also emphasizing what can be done in relation to prevention and promotion of brain health. I think you mentioned most of it, like nutrition, physical activity, sleep, and many others. So it leads me really to that notion of the paradigm shift that we see, that rather than to work on specific disease areas, working under the premise of looking at the brain not only as an organ and as an organ that can dysfunction, to a certain stage in a life course, looking at the brain as our best asset, as our capital that we need to nurture, capital that we need to invest into, is also leading us to embrace a storytelling that we see emerging at a global level and with partners in other regions of the world on this notion of the brain healthy transition of our society. You mentioned, Gregory, architecture, even urban planning. We see the emergence also of neuroscience-inspired design in all living spaces. So it's really a way by which we can embrace and embed this notion of preventing the emergence of mental disorders, but also to preserve and nurture well-being, which is probably the best way to prevent the emergence of brain ill health, because we know how complicated, challenging it is to cure and manage those disorders. So it's really this holistic notion that we would like to foster, and that translates into policy actions such as now the Brain Health Partnership that is now being discussed, that is going to be launched in 2026, that is going to be, let's say, the landmark in terms of prioritization and collaboration under the framework of Horizon Europe. There is obviously the Healthier Together that we would have liked the Commission representative to come and talk about, but maybe we can talk about it in the absence. So okay, plenty of stuff that we would like to come into it. And there is certainly more that I can contribute in the course of the discussion. Maybe a last word about an initiative that EBC has launched, the Brain Innovation Days. We were really glad and honored to have Gregory as a speaker, because it's debuting, and exactly to use your words, it's debuting this understanding that innovation is necessarily about deep tech. And it's really what we wanted to generate as a kind of change of mindset, that innovation is also about how to do things differently, not necessarily having new technologies. I mean, it can be accompanied by technological development, but it's also challenging ourselves in the way we are doing things. And it's basically referring to some of the projects and the recommendations we have developed around rethinking the way we are doing things. So here we are.
Thank you very much, Frederic, for this. I keep hearing, since the beginning, integration, holistic approach, paradigm shift. I mean, it's really a new approach to health that's coming up. Gianni Franco now from the Non-Pharmacological Intervention Society. Yes.
Thank you. Thank you, Frederic. I don't know if I can say more than you said, because it's a good summary of the situation. And as you know, I'm a clinical neurologist, and I am one member of the NPIS, but also I'm member of the NPIS, but also member of Belgian Brain Council, and so of European Brain Council. I'm member of the Belgian Association Parkinson, and so member of Parkinson Europe. But NPIS is not concerned not only non-pharmacological intervention and not only brain disease. It concerns all specializations in the aim of sustainable and integrative health. And maybe also NPS concerns all of us, because we are all of us patients in making. And I want to say also that NPS doesn't concern even only non-pharmacological interventions, because it concerns an active participation in a new vision of the organization of health, more balanced, and allowing all stakeholders intervene according to their respective skills for a preventive society that's more than simply a curative one. This humanist and scientific movement, the NPIS, takes part of the multidisciplinarity and interdisciplinarity, salutogenesis, early detection of diseases, but also of situation of overrun, and also support all along the pathway till palliative care also. The aim of the NPIS is to participate to preservation and improvement of the health of each individual, of society, and also of all the society in general, to improve health and quality of life in the long term, reduce healthcare expenditure, and trigger behavioral change. And faced with the obscurantism and ultra-cryptarianism caused by fake news about non-pharmacological interventions, it's therefore urgent to provide an European tool for the citizens, patients, professionals, and healthcare operators to be identified, evidence-based, manualized, targeted, and personalized NPIS. This will allow better choice, engagement, traceability, and possible financial coverage all along the whole health value chain. Indeed, in this rather complex health system with various predisposing and influencing factors, modulated by different cultures and paces of life, we had to focus on a single tool that was understood by all in order to recommend good practices based on scientific validation criteria, but also the knowledge of professionals trained in the NPIS. And for this, the NPIS produced a centralized European register of labeled, described, and codified practices, launched in October 2024 in Paris. And we also provide you with the NPIS guidelines, which can be distributed here right now, if on request, to our executive attaché, Baptiste Trichet, who is near our best and main organizer, Alain Warnery, in front of me. And this is a very interesting handbook because it describes not just the non-pharmacological intervention society, the scientific society, but also its ecosystem. And maybe also it answers to all your questions, the questions that you have asked to yourself, and all the questions that you don't dare to ask yourself about NPI, because it's a very tremendous subject to change. And this question in the field of evidence-based health solution applied in prevention, care, work assistance, social protection, and end-of-life support. Actually, and finally, our project is to participate in the implementation of an NPI compendium as for medicines, classifying the NPIs according to their indications, main benefits, secondary benefits, contraindication and risks, adverse and side effects, mechanism, target population, protocol with component, procedure, professional context of use, just to ensure a safety and traceability for the well-being of patients. And I can show you an example of our NPIS guideline and the book that you can obtain and receive just on request to our executive attaché, Baptiste Trichet, and also via online, and maybe it will be downloadable on our website since next week, I think. Yes, thank you. This is the guidelines.
Thank you very much, Gianni. Professor Iveta Lagiova, please, you were until last month, like the Commission, you were
Yes.
President of the European Public Health Association. Please, you have the floor.
Thank you very much. Thank you. Thanks a lot for the kind invitation, Gregory, and also for our hosts. So let me just briefly introduce myself. I'm just getting used not to be the president of the UFA after 4 years and 8 months. It has been the long period. So I handed over during the past European Public Health Conference in Lisbon to our new president, Tit Albrecht from Slovenia. So apart from that, I'm the head of the Department of Social and Behavioral Medicine at the PJ Šafarik University in Košice, Slovakia. So since 1995, my research deals with the non-pharmacological interventions and with behavioral medicine and all the mechanisms and measures, how we can help to improve the health and well-being and quality of life of people with chronic conditions. So basically, I'm a researcher. And with regard to UFA, whom I'm representing still here today, because my new role within the UFA is to be the chair of the EPH Conference Foundation, which is the largest public health event in Europe. And my new role is to create the program or co-create it together with our partners, the WHO Europe, the European Commission, and other non-state actors from Europe. And also, just like Gianni, perhaps I should introduce a little bit more of things that I'm doing. I'm also a member of several advisory groups at the WHO and WHO Europe. At the WHO level, it was the behavioral, the technical advisory group of behavioral insights and sciences for health. And currently, I'm also a member of the technical advisory group on building of innovation of ecosystem framework for public health at the in Copenhagen, so in WHO Europe, and previously several advisory groups on chronic diseases, NDGs, SDGs, and also research. I really like how this panel is complementary, and I will not repeat several things that have already we heard about. So I just would like to bring a little bit different perspectives and perspectives from the European Public Health Association, whom I'm still representing here today. so that you better understand why is it relevant also for the public health field. And we started this collaboration with Gregory during my presidency, and we had several negotiations and agreements like how UFA will be involved in the future. So therefore, I would like to present you the organization in the beginning. UFA is the umbrella organization for National Public Health Associations and Institutes in Europe. It has been founded in 1992. And we currently list 85 members from 47 countries. UFA operates also across so-called thematic groups of UFA sections dedicated, let's say, to chronic diseases, infectious diseases, epidemiology, but also mental health, law, salutogenic design and architecture, urban health, and many other fields. And we also are promoting and supporting the young generation. So we have a network of 4,000 young public health professionals. Within the context of the NPIs, I would like to present you now the definition of the public health as we, as UFA, understand it. UFA defines public health as the science and art of preventing disease, prolonging life, and promoting health and well-being through the organized efforts and informed choices of society, organizations, public and private, communities and individuals, and includes the broader area of public health, health services research, health service delivery, and health systems design. And very often, if you are from more traditional countries with more traditional public health, then you know that public health usually is understood as vaccine and hygiene, vaccination and hygiene. But as you can see, UFA understands it much more broadly, and therefore NPIs are perfectly complementary with what we are doing. And also, I'm very proud at our new UFA strategy, which highlights 4 elements, our 4 pillars, which is evidence, support and disseminate high-quality research to inform public health choices. The second is equity. UFA always championed inclusiveness and reduced health and inequalities, especially among underserved populations. Also engagement, that what we try to do is to foster cross-sector collaboration for community-driven health initiatives. And finally, empowerment is the 4th E, which stands for building capacity among public health professionals and communities. And again, you hear, you know, I was co-creating this strategy, and as I said, I'm very proud because it was already mentioned here that synergies, innovation is very important, and cross-sectional collaboration. And actually, this is what I brought to UFA, what was my vision for the UFA, to work more closely with other sectors, to work across disciplines, and also the innovation. It's very, very important aspect, because as we have heard, we have several health challenges, and we cannot overcome them without innovation. We have underserved, overstressed, underfinanced healthcare systems, and with current or traditional measures that we are having, it's impossible to tackle all the challenges that we are having with aging populations, increase in NCDs. And therefore, non-pharmacological interventions fit perfectly well with the public health initiatives and interventions, because they can make them much more effective and efficient. And there are also new tools about which public health experts never thought about. So, with regard to UFA and our strategy for years 2025 and 2030, another things which I would like to highlight so that you better understand the philosophy and the DNA of the organization, what we are doing is that we are a research-based organization, as I mentioned. So we are bringing science and policy, and we want to translate it into actionable evidence. The second is that we are, of course, supporting our national public health associations. The third is that we are promoting health for all through close-sector partnerships and innovation, as I mentioned already. And the fourth, which I have not mentioned yet, is building public health capacities, focusing also on resilience, equity, and inclusion. So these are our 4 main objectives for the next period. And we have several strategic themes, which again are perfectly aligned with NPIs. Innovation, mental health, resilience, even commercial health determinants, aging populations, everything is very relevant. We have these ideas also embedded into our strategic partnerships and memorandum of understandings. For example, with the WHO, we signed a memorandum of understanding in 2003. We have several topics that we are covering. Apart from those which I already mentioned, we are also covering behavioral and cultural insights as one of the topics. And also, what do I have here? Public health functions, primary care, addressing non-communicable diseases. And we have also several networks that we are collaborating with WHO as well, healthy cities, healthy aging regions for health, and WHO collaborating centers. And finally, why I'm mentioning our partners and specifically the WHO is because we as UFA and me personally have very closely collaborated also on the resolutions on behavioral sciences for better health, which have been adopted at the European level in September 2022 at the RC 72. And last year, in the 75th meeting of the World Health Assembly, it has been adopted also by the WHO in the headquarters. That means that all 149 countries committed themselves to promote and mainstream behavioral insights and sciences for better health. Why is it important? Why is it relevant for public health and for NPIs? It is, again, because it gives us a framework where we can operate and where governments already committed themselves with funding, with resources, with everything, which is a perfect way how we can also incorporate the non-pharmacological interventions, which are a little bit more narrow field. So this is it for me for the beginning.
With this very broad picture, maybe we move back to a practical field, or Russell Patton was Director General from Parkinson Europe. Please.
Thank you. I haven't been too well, and I noticed that my memory fails me, maybe just old age, so I will just look at notes, excuse me. So I represent a patient organization, Parkinson's, and something that Gianni said, patients in the making. I think we all are, and we will all be patients at some stage or other. The statistics are frightening. Secondly is huge thanks for inviting myself and the Parkinson's Europe, and to have, you know, patient organizations, you know, with you, amongst you. I think that's incredibly powerful. Listening to Angela from Alzheimer's, she kind of took my speech away, because I think a lot of patient organizations do very similar things. So what I did want to say about Parkinson's Europe, we're 30 years old. And interestingly, a lot of people think that, one, you die of Parkinson's. No, you don't. You die of all sorts of other things, but not actually Parkinson's, which is even weirder. And most people think that you have to be old to have Parkinson's. No, babies have got Parkinson's. Young people have, more and more people. And according to some neurologists, it's the next pandemic, and it's certainly the largest neurological disease growth. So it's frightening. And one of the objectives of Parkinson's Europe is to collaborate, cooperate with other organizations like yourselves, because we need to be better heard as an individual disease, which is tough, because I'm not saying that we are better or worse than another disease, but you know, you do have to speak out for your own cause a little bit. So Parkinson's was set up 30 years ago, and we are a pan-European umbrella organization spanning from the Atlantic to the Urals, via Ukraine, via Israel, and we have a very broad membership. We have what I would call the typical national associations of Parkinson's patients, but more and more we see small patient groups that pop up in the country around a particular theme or sport or an interest. And some of that is a lot around sport. And so, you know, an NPI is sport and NPI, and I'll come back to that in a minute. As Parkinson's, we deal with all sorts of things. Do we have a real impact? And at the end of the day, that's what's important. And I have to congratulate the WHO, which you've mentioned on more than one occasion, who, really actually through its epilepsy and neurological diseases action plan kind of put a lot of pressure on Europe to actually start to look at neurological diseases through the NDC chapter. But, we're sort of mixed up with mental health. So any platform that helps me to get the word out on Parkinson's is very welcome. So thank you for giving me this platform. I wasn't supposed to be here, so I asked Gregory, what should I sort of point out or pull out? So thank you very much. I think first of all, we recognize there's not enough research on NPIs for patients with PD in Europe, full stop. Parkinson's has no cure. Drugs and surgical treatments only provide symptomatic relief, but do not alter the course of the disease. Furthermore, they come with side effects and lose effectiveness over time. However, non-pharmacological approaches are already in use for years in Parkinson's to complement the treatments. These include exercise, physiotherapy, occupational therapy, dance, and art. And it's interesting that when we have an annual general meeting with our PWPs, people with Parkinson's, they get very excited when we talk about exercise, dance, and art. And we have a World Parkinson's Congress, which meets every 3 or 4 years. And alongside all the great discussions we have with doctors and HCPs, morning, lunchtime, afternoon, evenings, there are side events all around exercise. Ping pong, I just take that one, is an amazing sport that people with Parkinson's love. And we're even thinking of doing a Parkinson's Olympics. And when I speak to these people, they say, oh, I love art. I love doing all these exercises. They make me feel much better. Now, is there proof around it? I don't know. But I think mind over matter is very important as well. But of course, in the real world, we have to set a framework. So we are very much in support of what you're doing today. Not enough traceability of protocol, this has been mentioned. With more research and the support of solid data, standardized protocols should for the implementation of NPIs be established. This would support HCPs in prescribing this kind of intervention, in addition to standard drug therapy, and make sure that the care PWPs, people with Parkinson's, jargon, received is reliable and verifiable. Need for European register, we talked about it. The topic of European registers in Parkinson's is a challenging one due to the existence of 27 different healthcare systems, and we're not just EU, we're broader, we're Europe. And I would almost put total, I'm maybe exaggerating to make the effect, lack of data on topics such as prevalence, which at the national level can be very different. One of Parkinson's Europe strategy revolves around the need for better data about Parkinson's. Believe it or not, we don't actually know how many people have Parkinson's, but the estimates is there may be 3 to 5 times more out there than there are, because either people are misdiagnosed or have got Parkinson's, but are just not diagnosed. And all Parkinson's patients I've spoken to say to me, Russell, I knew it fundamentally in my gut 3, 4, 5, 7 years before they were officially diagnosed. Wow, we have some issues. The establishment of a European register for NPIs for Parkinson goes in the same direction. However, it is important to make sure that such a register is constantly updated and validated and accessible for HCPs. I can go on and go on. I think I just would say that there's a need of harmonization of NPI development process in Europe, which you've mentioned, and a need for better dissemination and training. Knowledge building of patients and their families. I'm sure you will agree with me that often it is the carer of the patient that runs the roost, accompanies the patient to see the neurologist, and is so intertwined with the life of the patient that they are equally important in the journey. their families is equally important so that they can be empowered to have a conversation on this topic with the HCPs and can have an active role in choosing the best treatment options available to them, including NPIs. Sorry for going on, but thank you very much for the stage. Much appreciated.
Thank you so much for this very humanist example. And I think that speaks to all of us. So for the discussion, I would suggest, the topic is so broad and so that we take a very scholar approach, one aspect after another. And maybe we'll start with the economical aspects. So with this idea that now we need to shift from science to practices, to implementation and so on. And it's even a broad field in public health, implementation research. So it's getting more and more important. So I don't know if Angela wants to say something, or we just move on in the room, maybe Frédéric. Economical aspects. I just say a personal one on that. I'm not, distinguished speaker, but the issue of financial coverage is of course a very big one. My experience is in France, the financial coverage of medicines is better, much better than in Belgium. But the financial coverage of NPIs is much better in Belgium than in France. So border countries, same language, same. Come on. No, please, just to kick up the discussion.
Well, yeah, it's an interesting feature, and actually, at our Brain Innovation Days last year, we had a session on this novelty we had in Belgium, which was the coverage of social prescriptions. So in Brussels, you could prescribe for revalidation of people with a mental health issue, and particularly depression or anxiety, to visit museums. So there was a partnership between the kind of League of Museums of Brussels and the National Security to get like a few tickets, because it's not the purpose of going on your own, but it's that issue of exposure to art, reflection, let's say, of your experience against art pieces, but also this social inclusion. So you're meeting already a couple, or you're hitting a few of those targets that we have in that finger approach, when we say physical activity, cardiovascular health, but also it's like social interaction, cognitive stimulation are really important elements, which were obviously recognized as a need, and the test is actually now renewed, and we hope to see it expanded. We can also relate to what Nordic countries are doing with go to the nature, take your backpack, and you have a kind of nature prescription by your doctor to really foster and promote your well-being and positive mental health. So this is evidence now. I mean, this is evidence because it is paying off, and it is evidence as also being something cost efficient in terms of what our, let's say, public health system is paying for. So the cost for managing brain disorders at the European level yearly was last estimated to 800 billion euros annually. So it's 7 times bailing out the Greek debt when we were in the middle of the sovereign debt crisis. And remember what it took to our leaders to take the decision to invest that sort of money. So let's say passively and without we realize it, we have this burden to society that we know of, that is probably doubled since then, and that we know is a ticking bomb. And we have those now big agencies that were rating countries during the sovereign debt crisis. Standard & Poor's has come up with the fact that if we are not doing anything, if we are letting it go, dementia alone. So, I mean, Russell was talking eloquently about Parkinson's disease. So that means that the forest of other neurological countries behind the tree of dementia are really a risk in long term if nothing is being done to the sustainability of our healthcare systems. So what are we now going to do here, and where are the political leaders who should now help us addressing that situation collectively?
Thank you. First of all, I just want to add that, as Richard Patton said, almost all clinical diseases are with a progression, very progressive and sneaky, since the diagnosis is posed, and we have to face not only to the wandering diagnosis, it takes very long time, but also in clinical signs, they are very untypical of the disease during 10 or 15 years, maybe. And maybe there is an opportunity to use NPIs, because in this period we have no medicine, just sport, maybe ping pong, boxing, and so on, and dance. Okay, so coding the NPIS, we know that, and it's obvious that NPIS reduce the health expenditure, the number of rehospitalizations, delays the time of a run, improve the adherence and tolerability of medicines, and participate in the broadening of the therapeutic education towards a school of life that takes into account the real multifactorial problems and expectations on the field. NPIS improve the quality of life and therefore the fulfillment and productivity of the whole society. The NPIS are also an expression of the public desire for greater proximity and alliance with the healthcare provider, not to replace conventional medicine, but to help it increase its effectiveness and a better compliance, avoiding the interruption of stock shortage linked to medicine sometimes. NPIs are therefore vectors of an effective alliance between all health care stakeholders with patients and their caregivers. And therefore, NPIs are vectors of unity of the whole society to actively and together cope the challenges for better life, better quality of life. Unexpectedly, but in the end, quite logically, we also have interest in discussing with the pharmaceutical industries, whose economic conception is associated with the concept of integrative medicine, because more and more, the effectiveness of a medicine is no longer evaluated only in terms of numbers and statistics, but how to be able to obtain from the patient the most satisfying answer to the only question that matters. And you, do you feel better now? For this, we must increase the budgets allocated to practical research in a vision of integrative health at a national but also at a European level, and ensure that political decisions on health must not be subject to electoral deadlines. Thank you.
Please,
Yeah.
Professor Nebula, sure.
Thank you very much. Very good interventions indeed, very good observations. So let me add a couple of few figures. We have here the numbers, and also probably it's not really a surprise to many of you that 70 to 80% of all healthcare costs are attributable to chronic conditions or chronic diseases. So NPIs have not only the potential to improve the health, but also achieve long-term cost savings. And therefore, they are very, very relevant. Therefore, also the resolutions which I mentioned on behavioral and social sciences and measures are also incorporating these ideas that these interventions, non-pharmacological interventions, compared to pharmacological or surgical interventions, are relatively low cost. But as we are discussing, they have to be registered, they had to be codified, they had to be evidence-based, and this is what we are talking about here. But let's go back to the economic aspect. So as already Gianni mentioned, the NPIS can help lower hospital admissions, but also complications and the need for costly medications. Very often, if we improve the mental health of the patient, also in return, the physical health can improve because of something what we call psychoneuroimmunology. And So NPIs have a great potential to deliver a significant return on investment. And the European Commission and also the WHO, as already Gregory mentioned, has highlighted it. But still, we need to do more about implementing, and implementation research is absolutely crucial here. We need more research which is testing the NPIs also from the economical point of view, and also to understand how it can be better incorporated into current healthcare systems, and what are the shortcomings, or what are the potential drawbacks or limitations of the legislative systems, also with regard to economies, and how to solve these issues, basically. So the NPIS support a shift towards value-based healthcare, as we already mentioned as well, precision medicine and personalized medicine and personalized care. So they can really emphasize the patient outcomes and the cost effectiveness. And by integrating NPIs into standard healthcare protocols, we can optimize the resource allocation, ensuring that both financial and human resources are directed towards interventions that deliver the highest impact. But let me also mention that economic benefits go beyond the healthcare systems, because when we have healthier populations, we have also more productive populations, and we have people who are less resilient on social support. And also this leads to more resilient workforce. So there is also this another aspect. But as I said, to achieve these benefits, coordinated actions across Europe is essential, and therefore we are discussing this here today, that a standardized evidence-based frameworks and NPI registry in France should and could be integrated and implemented also at the continent-wide scale.
Thank you so much. I don't know, Gregory, if you want to.
I'm just going to say something maybe very provocative. A few years ago, I said to P, right, we're going to go and talk to the Parliament, and we're going to talk about the burden of disease. And I went, ooh, don't use those words, Russell. We don't like it. We're not a burden. I went, ooh, we need to tell the politicians we are a burden, because we are for society. And then you turn it around and you say, actually, being a patient creates a lot of jobs. And politicians will move with emotion, but they'll move even more when you can prove that by spending some money, you get a return. I think somebody mentioned return on investment. If you had a bunch of 30 people with Parkinson's here, they would all say, Russell, please get money for me to play my ping pong. Yes, I need the drugs, but I get just as much from all these other NPIs. Now, how do you translate that and get it across to decision makers, busy decision makers? But it's food for thought rather than perhaps being provocative.
Maybe, to my opinion, two ideas. We think about direct costs. Direct cost, of course, hospitalization, drug, etc., but it's also indirect costs with the impact to the family, with the impact to the society, more larger. And we have to think, especially with big data, to measure all the impact, but also environmental impact. Because when you use maybe a robot from the US, the impact is very expensive. And my second idea is the oldest view of medicine: one problem, one solution. But it was the last century. Now we have complex disease, especially with elderly aging. It's a complex disease with maybe not only Parkinson, but depression, but anxiety. So it's a multi-complex, multi-dimensional disease, very complex, more individual. And the solution, it's not only one, but it's a combination of personalized solution. So NPI is not the solution. they will be one or the part of solution. And of course, the research and the funding, especially in Europe, about that is not enough. And in France also, the first reflex during the COVID was we have to find some solution only with drugs. But what about also non-pharmacological intervention? Where are the investments? Because it's not only a burden, it's also an investment for the new generation. And it's absolutely impressive that young doctors, especially in France, maybe because they are women, they are more, they can understand more the need of the patient and to be more open to solution and to develop some propositions. So we think that NPIs, it's not a burden, but really an investment from research to practice, but we have to improve the quality, the traceability, and the efficiency, of course.
Thank you so much. Yeah, I think our decision makers really need cost-benefit analysis. I mean, any evidence, any publication you have on this cost-benefit analysis, meaning, proving that the cost of inaction would be higher than the cost of action on NPIs would be really beneficial. Anyway, for any public good, actually, it's the same with climate change or any, biodiversity. You need to show them that the cost of inaction would be higher than the cost of action. So maybe shifting to the regulatory aspects. We heard a lot about need for standardization, harmonization, and so on. Regulation is a bit further, is something binding. So please, we would be pleased to hear your views. Do we need regulation on NPIs, or take it easier? At least what you think regulation could bring.
Well, actually, I was thinking when I received the script and the topic on regulation, I was taking it the other way around. Maybe is how the clinical validation of NPIs can actually be robust enough in order to be recognized by regulators. And that would then come across what you were mentioning about prescription and even enter the kind of HTA process in a sense, because we need the recognition of the integrative approach. And that's probably what we are struggling with. And sorry, Cecilia was saying, I've heard a lot about paradigm shift, integrative approach, holistic, etc. But that's because this is what we need. We can't look at things in isolation. I think Russell was illustrating that brilliantly. So it's not the problem we've got is that the EMA is tasked to look at the intrinsic added value of a pill that they are receiving against like, other pills on the market for similar indications. And they wouldn't look at the care pathway, the integration, or the holistic approach and holistic management that is necessary, particularly for diseases as complex as neurological and mental disorders. So here, maybe a reflection about the mandate of our regulators or the expectations that we've got towards regulators. So the irony, and that's probably a key point here, is like the irony talking about non-pharmacological intervention is to say we should plead for the pharma legislation to change the way in the approach of the mandate towards the EMA. So that's probably a first point I can bring in the discussion.
Thank you. So it's a very difficult game to play, and we have to play together for this. And there's something that are done yet, because and it's important to raise awareness and promoting alliance for the development of NIP between citizens, researchers, health operators, health professionals, health funders, politicians, and regulatory decision makers. It's also necessary to convince through communication, and a communication understood by all, to seduce with justified arguments, to build a society that is more and more active rather than dependent and passive. The regulation are indeed very heterogeneous and vary from country to country, or sometimes even from region to region in the same country. In the Northern European countries, NPIs are already officially taken into account and reimbursed. And for instance, in Belgium, some mutual insurance companies have already set up partial reimbursements. On the other hand, in the USA, given the highly competitive context promoting short-term financial benefits, health policies favor mainly the promotion of drugs, technologies, and surgery. But this might be the sign that it's necessary, very necessary, to encourage studies and research to show the economical benefits of NPIs, and so introduce some humanism in the health economy. Just to say that in this economic and regulatory framework, the 3 books produced by Michel Nogues and Gregory Bonino are at your disposal also by contacting always our executive attaché here present, Mr. Baptiste Frichet, in front of me. Thank you.
Thank you, Gianni. Well, yes, I think while listening to you, I'm also thinking whether it is a difficult game to play. We have some examples from the past, for example, the European health data space, but I would say that it's definitely not an easy game to play, to have the standardized and regulatory aspects and legal aspects, but they are absolutely necessary. Because the current landscape of NPIs is very fragmented. There is a significant variation between the countries in these interventions, how they are defined, how they are regulated, how they are integrated into healthcare systems. And the lack of standardization across countries poses several challenges. It creates confusion for patients and healthcare professionals, also limits access to effective NPIs, and makes it difficult to ensure that interventions are evidence-based, safe, and delivered by qualified professionals. So therefore, the European regulatory framework for NPIs should address these issues and should provide a clear standardized definition and guidelines for the development, validation, and implementation of NPIs. And it also should ensure that NPIs are subject of the same rigorous scientific scrutiny as pharmacological treatments. And I know that this is your dream, Gregory, that you want to achieve basically the same thing. And you also try to explain people, why do we need a registry? Why do we need a codification? Why do we need a stamp, so to speak, on the NPIs? And it is very easy to understand if you use this example that we have to have the same system as we have for pharmacological treatments. And this would guarantee that only evidence-based practices are promoted. And it should also establish a professional standards for delivery. And we will talk about it also later, that what does it mean for healthcare providers. But it basically means that only professionals that are properly trained and accredited can provide or perform these interventions. And finally, what this harmonized regulatory framework would facilitate is a cross-border collaboration and cooperation, scalability, and also it also would support future research and innovation, because, you know, when you are collaborating across countries, it is also a great source of innovation, encouragement, and development of new effective NPIs, for example. So let me just conclude that by creating a coherent, and I had to write it down, coherent evidence-based regulatory framework, Europe can lead the way in integrating NPIs into mainstream healthcare, ensuring their credibility, safety, and widespread adoption.
Yvette, I think you said more eloquently what I was thinking. So I agree. When I saw this as a topic, I sort of thought, you know, to be or not to be, you know, to regulate or not regulate. And representing a patient group, we're always a bit worried about regulation. So if we want to go down the route of regulation, let's be 300,000% sure that we know exactly what we want in that regulation. Because when those decision makers get their little paws onto it, they will change it they'll make it cheaper, etc. And I was just wondering whether we should look at the regulation of pricing of drugs and availability of drugs in Europe. It's a bit of a mess. And if I had 30 patients here, they'd say, well, you know, in Portugal, I can get this drug for free. And the German will say, well, maybe that's a wrong example, but yeah, the German can't even get that drug, let alone for free. So there are a lot of issues there. And maybe we should have a reflection on, you know, yes, I think there should be a regulatory framework. I think yes, but let's be careful and let's see, are we absolutely sure that we can push through what we ideally want as a community? So food for thought, and I don't have the answer.
We have, especially maybe in France, a confusion between the efficacy of the intervention, the reimbursement, and the regulation. And we have now maybe some confusion because it's reimbursed, you can use without any evidence. So it's easy for a drug to have a clarification about what is a drug, what is a validation process, and the lawyers are very clear about that. It's now in Europe for medical devices. It's also now a product very clear to have a stamp CE, European Commission, but for the services, especially for targeted services, it's not clear. It's absolutely not clear. And because it's not clear, a lot of persons from a lot of countries say, I have the solution from my country, and it could be pseudo-scientific system, maybe with sectarian solution, and a lot of confusion between what is health solution in one part and another part, something more cultural, spiritual. And this kind of confusion is very dangerous because you can have a psychological danger, emprise psychologique, manipulation, psychological manipulation between the cultural aspect, way of life. What do you want? You want to go to church, etc., to museum? It could be just advertising moments, and it's not a health intervention with a health professional, with an ethical viewpoint, with a training, and explain why it's really efficient in what kind of context. And now we have to invite the lawyer to think about that. We can have, and last but not least, for researcher, a number of publications with absolutely the same study, with the same non-pharmacological intervention in Canada, etc., etc. The same study. If it's efficient, safe, explainable, why reinvent the wheel? Because okay, it's from New Zealand. It's the Otago program is really a good example. 40 years in New Zealand to develop a program to reduce the number of fall of elderly people. Why share the knowledge everywhere and maybe invest for research? Of course, for the unknown zone, but share the knowledge that this program is really efficient. And the confusion, especially because of journalists, because of maybe some person or some companies, oh, you can use this traditional medicine, you can use this, but it's not health, it's only advertising, and we have to get more clarification. So the lawyer is needed to that, and politician.
Thank you so much. I think it's a good, excellent point for our politicians, to show that basically there are economic interests manipulating this lack of clarity. And it's a huge market, you know. Well, whatever, I mean, especially in brain disorders, but so that's really clearly where the regulators, where the public service should act. Maybe, well, there were already some words about the training aspect. If you want to add something on the training, maybe, because it's very clear that only trained caregivers, health professionals will be able to translate that, put NPIs into practice. So, yes.
Yeah, well, the thoughts I had around that were probably first and foremost to reflect on what we could hear from within, let's say, clinical practitioners within EBC, who are actually believers and promoters of NPIs, but who are saying like, yeah, but most of the time when we talk about that, it's not taken up or recognized because it doesn't look serious. Or it doesn't look serious enough in science or in clinical practice just to say, look, you should, you know, go out and have walks or play ping pong or, you know, walk your dog or, you know, God knows what. But it is recognized that, I mean, in a stage of life of, you know, being as young as we are on the panel, starting to play a music instrument or, you know, getting to learn a new language is the best way to keep our cognitive reserve until late in life. Like neuro revalidation and Russell, you mentioned physiotherapy is also one of the best thing to stimulate physical activity. Whilst in the past, in clinical guidelines, you know, if someone had a motor neuron disease, the reflex was rather to say, no, let them rest because they are in pain, or we should probably let them go. And then we see the deterioration going way faster than actually physically stimulating that person on a daily basis. We have currently on our board the past president of the European Psychiatric Association, Professor Falcai. He was at a conference in Brussels earlier this week and proudly sharing with us the current research that he was doing on the impact of physical activity, and particularly ping pong, in the management of severe depression. And his work are actually showing very clear benefits also in psychiatric care. It also relates to cycling and the vélo d'appartement. So half an hour is enough to have significant improvements in outcomes. So that degree of scientific but also clinical validation is definitely a key factor in making sure that it then enters the dissemination. Well, maybe I should anticipate item number 5 also in dissemination, but entering into the work of medical societies, but also entering into clinical curriculum for the next generation of practitioners.
Thank you. It's a very vast subject to discuss, and a sentence that it reminds me. In French, we say "Aide-toi et Dieu peut-être t'aidera." Help you and maybe God or paradise help you if it exists. But something I really just done now, and it's health that we are talking about, and life cannot be reduced to the NPIs alone, right? The learning of NPIs must be part of a wide, multidisciplinary and synergic movement, including the exchanges and expectations between patients' associations, the partner patients, their caregivers, the health stakeholders from the medical and paramedical world, pharmacists, economists, sociologists, ethicists, philosophers, and the cultural and sport world, with ping pong, for example, in order to best preserving and improving our health. It's also necessary to educate all of us, maybe already before primary school, on the sign of early detection of overrun situations and diseases, and to nurture the most effective and wide interdisciplinarity, maybe to build a progressive and tailored transdisciplinarity. We must combine the NPIs with advances in artificial intelligence and environmental studies, genetic profiling, and the sharing of personal data, as we have said. We must support together the awareness campaigns, as European Brain Council has done a few weeks ago, to better clarify the definitions of NPIs. We have to clarify it, and to remove them from their reputation as difficult procedure faced with the magic drug, which, as we know, doesn't exist. For that, the NPIS has designed 2 international open badge training programs, practice and science. Each course is divided into 3 modules: knowledge, know-how, and interpersonal skills. Equivalences can be granted on request, depending on diplomas, qualification, and professional experience. And you can find more details in our gorgeous guidelines that you can receive it. Thank you.
I think I'm going to be inspired by Russell, and I'm going to have more questions than answers. Yes, because when I was thinking about it, about education and training, clearly there is a gap, right, regarding standardized education and training in terms of NPIs. But the question is how to do that. And I really like what you said, that people are not taking it seriously because it's not embedded in formal education. The question is how to do that, because when I'm at different fora, I hear about different things, like we should educate medical doctors more about AI. We should educate them more about economic aspect. We should educate them more about management. So is there really space for more education, so to speak? I would say that perhaps we have to be more effective how to do that. Maybe we have to communicate with people who are putting together the educational programs for the medical doctors, and definitely, as I said, I do not have an answer. So I think we have more challenges because the healthcare systems and the landscape is changing so rapidly that the standard educations which we have are very slow in adopting and adjusting to the ever-changing landscape. So what can be done? Basically, what UFA is doing, and I'm not saying that it is the answer to everything, but perhaps one part is definitely continuous education through the workshops and through what you are doing, so that people can be more flexible, and if there is something new, interesting, relevant, so that they can learn it very quickly. But at the same time, I also believe that there should be some notion also in the standard education of the medical doctors, of nurses, of psychologists. So the question is how to do that wisely.
Nothing to add, except that one patient told me the best treatment he has is the dog walking him.
Maybe 2 remarks about training. The first one is that health practitioners are trained to understand mechanism in part, and trained to have techniques. And they go to work and to create with models, physiopathological model or psychopathological models and techniques, and reinvent the wheel. And maybe it could be useful to have a real training to the program, to the protocols. And I remember in an airplane security, when you are a pilot, plane pilot, professional, you have, of course, your brevet, professional. But if you want to flight professionally to one or another plane, you have to obtain, you must obtain a qualification for this plane. And it's probably important for a physiotherapist, for a psychologist, not only to have a theory and techniques, but also have more training about the best practice and the real practice. I think the continuous training need to be improved, and not only the beginning, but all around the life, professional life, to have a more precisely details about the intervention. And the second aspect is because of global health, because of One Health thinking, we think that we need a glossary of health terms. It's absolutely unbelievable that between social workers, professional in prevention, end of life workers, and maybe also work health workers, they don't use the same words to qualify what is prevention. It's a big debate. Primary prevention, secondary prevention, tertiary prevention, and they don't talk in the same way. So probably non-pharmacological intervention, and if we can have a success today, is that you can use the term NPI and to have more a clarification, and it could be the beginning of for any researcher to define clearly a topic and to design the intervention and to share the intervention. The training is really a major topic, and it's also a topic for physician doctors. In France, 5 years ago, they create a mandatory course on NPIs. Maybe a lot of hours training, explaining drugs on medical device and surgery, but nothing on NPIs. And now the young doctors have a specific dedicated course on NPIs. It could be useful at the European level to mandatory courses on NPIs could be useful also. A dream.
Education and health.
A dream.
Well, just a change of the European treaties. No, education, training, you know, and health are both still exclusive competence of the member states, which make, of course, your work. But maybe WHO training or whatever, glossary, at least the glossary, you know, could be at WHO level and that.
Well, just a very quick comment, but it doesn't mean nothing can be done. So, but it needs to come from us rather than wait that it comes from them. So
Definitely, we are here. There's a question from the room.
Thank you for very elegantly explaining the need and the actions that are necessary. And I realize that you emphasize how important training is. But I think we expect too much from medical doctors. I think medical doctors are already doing too much, treating and understanding the patient. And I'm curious about what do you think, like we already have physiotherapy, we have psychologists who support a whole human health and whole human being. What about the use of people like health coaches, for example? I'm curious about your take on having other people actually who are more like translators, I think, between the science, clinical practice and the patient, who can understand what the patient needs. Maybe it's just a dog walking them, right? We can explain them, also support them in behavior change, because medical doctors are already doing too much. Like they don't, I think, have the time to necessarily follow through for the behaviors to change. I'm curious to hear your take on that.
I agree with you, but now in chronic disease, for example, care, we have a staff. So it's a collective decision also to, and we need registry, maybe, absolutely.
I agree as well, and that was my primary concern. But actually what medical doctors need to understand and what is still not really happening is integrated care, for example. They are not taught about integrated care. So like Gregory mentioned, they do not need to understand every single, and it would be impossible basically for everybody to understand the mechanisms of every single NPIs. But the medical doctors, for example, have to understand the mechanisms and principles and that it makes sense, you know, that it is not just for fun, but it is something real, which can be a real game changer. And I would say that within this context, they should have education, which is still lacking, and also multidisciplinary teams embracing more professions. This is still not happening in the medical field.
I agree too. But I really agree. But you know, the organization of health chart is changing also. Before it was a pyramidal structure. Now it's less pyramidal one. And the doctor is not alone at the top, but it's on in the organigram of health. And this is very interesting because it gives the opportunity to the other stakeholders to participate. And for instance, I'm not in capacity to discuss about osteopathy. So I need to have the experience and the knowledge of an osteopath to discuss of him. But the doctors have to remain at the centrum of this organigram of the health because they have the responsibility of the diagnosis, of the treatment, for pharmacology, and also in the prognostic, and maybe participate actively in using the coordination multidisciplinarity. So we can be optimist. The future is yours.
Just quickly to say is, that there's a huge burden on doctors, neurologists. The statistics for Parkinson's is that, there are very few neurologists who are specialists on Parkinson's. So certainly in some EU countries, or non-EU, the UK, but Ireland, we're pushing for more and more Parkinson's nurses who are starting to fulfill. And interestingly, my president, Josefa, is a health coach and works with the doctors and not the patients. We don't like calling them people with Parkinson's. And they sort of bridge or fill that gap. But I agree totally with Gianni that the doctor has to be at the center of it. And I think sometimes we feel that the doctor should have all the answers. And it's just not possible. And I think the pressures you're all under are huge. So we're almost starting to say we need to redesign our whole health structure here, but that's another question.
Body communication between the patient and the health operators. There is a difference with the communication. For instance, I'm working with my wife. She's a Parkinson nurse, and the patient sees her before me. And so when he comes to my desk, he said to me, "But I've said all I have to say to the nurse, to the Parkinson nurse, because the communication is different. It's more fluent maybe. It's more sincere maybe. And so we have to create a sort of communication with more empathy. And maybe in the education of doctors, it's not very clear as to take into account this communication empathic. But I'm optimist because universities and also other academies are very sensitized for this point. And again, the future is ours.
Yeah, just a quick word on that, if I may. Yes, the expectation to doctors is super high and is probably skyrocketing, but don't forget that health is the #1 source of concern and priority of our population in Europe, according to Eurobarometer. So it's not coming out of nowhere. But in terms of, let's say, the burden, I don't think we are here talking about adding 10 new modules to medical curricula or 2 more years of medical training. Doctors' competence is made of knowledge, skills, and attitude. So it's acquiring that new knowledge, being able to implement it, but also being open to, and probably along the lines of what Gianni was saying, is changing also behaviors when confronted with patients, just to say, doctors may not have all the answers, but being ready to look for them, being ready to look in collaboration with multidisciplinary teams in order to provide the best answer to the patient needs. Yeah.
Just say we should be like a football team. You have the manager who's the doctor, and that person is surrounded by many, many experts. So something to think about. The healthcare team. Who's the referee, though? Yeah, let's not getting into it.
Maybe another question in the room, and then we make a final round, maybe a conclusive one, merging digital dissemination aspects.
Yes. Hi, everyone. Sarah Bidbol from UFA. I'm the new policy officer in Brussels. I just have more of a general remark that can maybe bring some food for thought. So my background is that I'm a lawyer. And when we talk about burden, I immediately go to burden of responsibility as well. And maybe something that when we talk about training, of course, we need to train doctors, but I like the idea of empowering all the healthcare team that you mentioned. And one argument that could also convince doctors is also to share this burden of liability, which is also one of the reasons why doctors sometimes do not take more time with the patients, because they have so much paperwork and they're feared to be hit by a lawsuit anytime. So maybe it's something to be thinking when we're talking about advocacy and changing policies.
Well, when I hear burden, I tend to be like Russell, more the burden on the families. And I think, okay, the health team, the whole health team, yes. But in the end, the only ones, I think my experience, having the overview on all what the patient has tried, be it nutritive, is the family, the aidant proche, as we say in Belgium, the caregivers. Most of the time, the family, they are doing this coordination role, informing, the neurologist, the medical doctor, giving what has been said to all physiotherapists. But that's something burden for caregivers, big issue. Maybe you don't mind if you have lunch at 1, then maybe. Being the interest, please.
Just to remind what Gregory has said before, because there are the burdens, direct, indirect, and also the very masked and sneaky problems that we can see if we don't live it. And so maybe the 2 words to underline, to highlight, is communication and awareness on the field.
So maybe to give a tool to the doctors, to the whole team, the digital aspect. Digitalization is a tool, not an end in itself, but please, if you have any insights.
Well, before providing the insight, again, I had a question, is like, when we talk digitalization, are we talking about like the tools and the disposals of the, let's say, healthcare workforce dealing with people with a condition in patients, or are we talking about interventions per se? Because I think, Gregory, you alluded to it, yeah? And I don't want us to be bugged into the discussion around the definition. But immediately when I was reflecting on digital, I was thinking of telemonitoring, tools for early detection, early intervention. I mean, we have demonstration of that, and also in our rethinking project, we have had fantastic demonstration of the ways by which, obviously, COVID has become an accelerator of the adoption of these technologies, and sometimes, well, or most of the times, because of the necessity and the dire need, by doctors who were definitely not fans of these tools for teleconsultation, telemonitoring, and all the rest of it. But because they were forced to use it, discovering the added value and being then the best promoters. And well, what I like in that story is that it doesn't finish there. It continued in our interview when that doctor, that clinician said, actually, we're now thinking as to how we should embed that in the care pathway of the future, because we have seen patients like we've never seen them before. They were at home, they were functioning in the environment, an environment that they know. We could see them walk without too much problem, or sometimes with more problem than when they come to the clinic. Coming to the clinic sometimes take them a full day for seeing us half an hour, not even. So we see that there is definitely a benefit for their comfort, and also the caretakers around them having to organize like the journey to the hospital and all of that. So the reflection was like, we should not transition to a fully digital monitoring, but it's a blended approach. But before considering that, we should ask the patients what they think. So even the co-decision and the design of the pathway of the future was really built around this co-decision. So basically 2 revolutions in one. Maybe another one that I wanted to throw in that notion of early intervention, and something that we see emerging, is this whole thing about neurogaming. So again, you know, about not taking intervention seriously. What can you not take less seriously than gaming and having fun? But neurogaming is really a field in emergence for the early detection of cognitive issues and primarily mild cognitive impairment, but is also a tool for revalidation, and particularly in the context of stroke, other neuromotor disorders such as Parkinson's or AMS. So it's definitely something we can think about. But I don't know, Gregory, if you'd like to embed the whole of telemedicine within the NPIs, because then it's probably getting a huge load. But very happy to look into it.
Thank you for this good summarize. And neurogaming has talked to me because it's talking about pleasure, and pleasure is emotion. And we know that there are no motricity without memory, and no memory without pleasure. And so it's a good tool to use. And the main question is must we be afraid of the artificial intelligence? But no, straight away, no. We have to learn just to manage it. And thanks to the maturity of digital technologies, a process of harmonized regulatory reappraisal of NPIS is possible at the European scale. Besides, artificial intelligence will allow us to optimize the use of data in the form of the big data, which continues support and not only punctuated by consultations. Multi-parameter support and therefore more complete. Remote monitoring, improving the proximity of care, and while also reducing the risk of human error. By reducing the administrative burden, artificial intelligence should also allow us to increase the listening time and communication with the patients, and so, among others, maybe improve the best therapeutic adherence. It's a very important point. AI could also maybe promote the early detection of disease and thus push insurance to intervene earlier with NPIs to break the spiral of complication due to disease. And finally, the wide multidisciplinary dialogue on a careful but essential sharing of personal data, as Roland Pochet has said to us, and the use of artificial intelligence will open us up to new realities, questioning our habits of classifying diseases and how to intervene in the most appropriate way. But taking into account the extreme speed of AI evolution, there is a very big need to accelerate legal and ethical adaptation too, as you said. Thank you.
Thank you very much. I think digital health technologies is a very exciting field, and I agree with my colleagues. And I also believe that digital tools could revolutionize the delivery, monitoring, and scalability of the NPIs, making them more accessible, making them more personalized and more effective across Europe. And I would like to highlight a couple of things, maybe 3 things this morning. For example, one of the most significant contributions of digital tools could be, or to the NPIs, is the ability to leverage data. And what I mean by that we have digital platforms that enable the collection and analysis of patient data in real time. allowing for personalized interventions and tailored individual needs. So, for example, wearable technologies, which are monitoring the physical activity or sleep patterns or stress levels of individuals, can offer and are offering immediate feedback to the patient, but also to the medical doctor. They can guide patients through the evidence-based interventions. And the level of personalized engagement ensures that the NPIs is really addresses the unique health challenges of the individual. And we in Košice have a Horizon 2020 project about experience sampling methodology. It's in patients with mental health problems, which contextualize their mental health problems in their everyday life. And interestingly, somebody said that the medical doctors are very open to use the new technologies. It is not true in our case. It is not true. So the patients were very open, they like it, but for the medical doctor, it's sometimes not easy to start to use the new technology, digital tools. So it is an implementation research is one of the problems that we have to overcome when we want to implement more digital technologies into NPIs or in healthcare systems in general, how to make it more attractive and how to make it more easy for the medical doctors to understand or to use. And you mentioned also the underserved areas, rural areas where NPIs could be delivered, for example. Another issue is artificial intelligence, like you mentioned, Gianni, that the artificial intelligence and data analytics can optimize the NPIs by refining interventions and identifying trends, and also helping us to scale effective practices across Europe. And finally, what I would like to mention here is standardization and interoperability, as we already mentioned, because they are the key, and technology can support the standardization of the NPIs, because the platform can provide the opportunity to centralize NPIs, and also the digital interfaces can integrate tools like NPI registry into healthcare systems, that ensuring that interventions are consistent, evidence-based, and easy to adopt by both healthcare and professionals. So this is my take on digital tools.
Maybe I have just, sorry, two ideas about that. First, when you think about Elon Musk and the American vision of health in the future, only treated by robots and only maybe using neurostimulation and maybe Amazon, it's not the European way. Transhumanism could be useful, but the reality of the Europe is humanistic treatment and humanism and patients care by humans. And we think that we have to create a strategy to have humans treating or helping another humans. And new technology could be a real guarantee to have this security, human treating humans, and not only robots treating humans. But sorry for this philosophical viewpoint, but we think that in Europe, humans want to be treated by humans using technology, but not technology treating humans, etc.
Even the European Commission? Do you think?
I don't know. We hope that it could be useful, and you're right. And the second aspect to the European Commission, they are very clear about the products, about industry or the products. But we have a study in Hospital of Montpellier, data mining, or all the data patients. We have a real clear view of the drugs of medical device prescribed in the data center. But for non-pharmacological intervention, physiotherapy, psychology, etc., it's just a session of what? Of physiotherapy. But what is it? It's really blind. So if we have a register with a code for each NPIs, we can have a traceability And tomorrow, with artificial intelligence, can maybe have a good combination, association between codified NPI.
Il n'a pas l'accent, hein,
and,
Grégory?
sorry. Merci. Il n'y a pas de son. That's it, to my opinion. See, can you hear me? Next question.
I don't know if
You know,
participants online can hear us with this micro.
is
that
it
any
part of
better?
your micro or microphone maybe?
Okay, maybe we do. We try to fix it while continuing
Can I continue just
in the
one
late
more?
hour, but please. please
Because just to say that there is also legality problems responsibility. Because if I am a doctor with my experience and I conclude that this situation is for this situation we have to choose a sort of treatment, and the digital analysis said to me, you know, you have to choose another treatment. What treatment we have to choose, because there is a legal problem. And so we have to adapt very quickly the legality, the legal evolution to the digital evolution also.
No, we switch to dissemination aspect, maybe.
All right. Grégory, I like what you said about the, well, the example you took that was probably extreme, but sometimes extreme example can inform us. So robots taking care of humans. So where shall we put ethical considerations when it comes to end of life palliative care, or let's say use of resources? So we've got obviously SF movies inspiring us on that, or probably frightening us if we think too carefully about this being, let's say, predictive models. But this leads me to let's say the number one point about dissemination, which is the degree of understanding, consensus building, but also making sure that there is a kind of cross-discipline understanding of what we are talking about when we look at the management of conditions and NPI, so not only scientists, but humanities, sociologists, philosophers, and hence the reason why I relate to your example. We've talked about clinical validation, so I will not spend more time on that. But I probably wanted to, as a way of conclusion on my side, also share with you two ideas or avenues of project development for us in 2025, 2026. Stemming from activities, and these were presented at the Brain Innovation Days, and we are now looking forward to let's say putting them in practice. And it's really along the lines of NPI on one side and caregiving on the other, and intimately interconnected. So we had a presentation of a person having run Ironmans, 5 Ironmans against Alzheimer. So when his dad was diagnosed, so his last name escaped me, but it's Hassan. He came to us, and now we are looking into partnering in the context of what we had initiated under the logo of Move for Your Brain. So it was really this promotion of any movement, so dancing as well. It's not only running, but any physical activity could be a source of let's say positive outcome. But then what they are doing is also to start collecting data and creating a longitudinal cohort about the benefits of physical activity, particularly Hassan, as he has allegedly a genetic predisposition towards Alzheimer's because of his father. But we also wanted to connect this to another project which we are now considering about, which was summarized as the caregiving genome. So it's basically enabling a data collection of the caregiving experience that relatives in the family, I mean, basically the interaction and trying to capture the interaction that they have had with their close one living with a condition, to make sure that we can capture that again, relating to your example of like one session. What does it mean? What does it translate? And I think, Cécile, you were also saying that caregivers are very often the best able to understand when something is going wrong or when they see an acceleration of the disease or further deterioration, because they know the person in question better than anyone else. So, and far too often that feedback or that input is disregarded in the care pathway. But what matters, and linking back to what I said about regulation, what is lacking is maybe having a recognized and validated robust data collection in that respect. So the understanding of patient-reported outcomes or even the input of caregivers is there. I think the degree of awareness of that value is there. Problem being is like, yeah, but how can we use it? So how can we use it in an assessment process, in a and basically in a regulatory context? So this notion of robustness, recognition, and validation needs to work in the right triangle, and we are up to take up that challenge in let's say exploring how an integration of basically it's a US initiative, this caregiving genome, but we'd like to create a European chapter in that respect. So let's see what it gives, but we are hopeful to bring benefit in that respect.
Thank you. Yeah, you know, we have also experiences in Belgium with the APLC, Together for the Brain Society, that we have created, and it's member of the Belgian Brain Council. So we have created a network of competent sentinel, taking into account all the stakeholders, the medical, non-medical, paramedical, and also the aide familial, the familial support. And so we have given them not the scientific explanation of all the diseases, but just red flag. At red flags, it's sufficient to induce taking of the taking of the problem in the beginning, and it's very important for us. And so it's a very large network like in the brain. Very efficient. And what I want to say about dissemination, it's already now, NPIs are already used everywhere and often without any medical prescription and with random efficiency. And sometimes even with negative health impacts linked to the fake news, making them appear as alternative and not complementary solutions. The NPI registry that we have done is a basic tool, a concept that will be tailored in its use and not in its content, depending on the country and region, the cultures and local regulations. But each country can also submit NPIs linked to their own expertise on the field. And finally, just I'd like to give you some words about the network of European and world context that we have already established with the NPIS International Development Delegation. We already have more than 1,000 contacts all over the world in different countries on the 5 continents: Europe, Africa, America, Asia, and also Oceania. These contacts support the NPI model concept and are ready to contribute to this dynamic of broadly multidisciplinary and synergic thinking about non-pharmacological interventions. Future is our.
That you say that future is bright. We have to be optimistic. Yes. Well, with regard to dissemination, let's be honest, the impact, how NPIs will be effective depends heavily on dissemination, but the NPIs which we are discussing this morning today, so the standardized, registered, clear, not the fake news, not the charlatan NPIs. This is very important to highlight again. But without widespread awareness and education and accessibility, the benefit of NPIs will remain just to a small portion of patients, just like maybe in France or Montpellier. So we have to do more regarding the dissemination. And dissemination is also essential in bridging the gap between scientific research and real-world application. And as we keep repeating, the evidence-based NPIs, such as those catalogued in NPIS registry, must reach the healthcare professionals, policymakers, and most importantly, the patients. And this requires coordinated efforts to share validated information through accessible platforms and clear communications. And I think we can learn quite a lot from you, Gregory, what you are doing here, because the registry is already existing. So this is a clear communication platform, which is accessible to healthcare professionals and also to the patients, but in different levels. So the healthcare professionals can go more in depth, whereas the patients just are giving basic information, which is, and policymakers as well, which is relevant for them. With regard to healthcare professionals, of course, they play a key role, and we spoke already about the education and training, so I will not tackle upon that. But what I would like to highlight, what we did not discuss yet, is public health awareness campaigns, for example, that are also equally important. Again, citizens, patients need to understand what NPIs are, to distinguish between charlatan and proper NPIs, what are their benefits and how they can access them. And also digital tools, community outreach, and partnerships with patient organizations can all contribute to spreading this information. Again, Gregory is doing a wonderful job. You have a lot of partners in France, and we have to make it more wide at the European level. And finally, what I would like to highlight are policymakers and regulators who should prioritize NPIs when we were speaking about economic savings and so on, by embedding them into national and European healthcare strategies. One important thing, that dissemination should also include ongoing monitoring and evaluation. This we did not discuss today because sometimes the interventions or some circumstances can change. So we also have to adopt our NPIs, that this will ensure that interventions remain relevant, they remain evidence-based and impactful, and only through all these efforts, the dissemination will be the key that will be unlocking turning innovation into action. So, and only by then we can improve the health and well-being of the patients. Thank you.
I'll be really short. I think dissemination, call it marketing. It's, we're driving a car or a truck with a few wheels, and if you don't have that dissemination, you're not going to go anywhere. And I think the thing to think about is, there's a lot of great consumer products out there. I just read recently that the air fryer is a very old technology, and we're only now starting to use it. It's been around for years. 50% of Belgians now have an air fryer, and that was through massive marketing. The iPhone, massive marketing. So we've got a great product in the making, but if we don't disseminate, market, get it out there, we've got a long way to go. And just to add something, I think you mentioned it, health is not a competence per se of the treaties. I heard Ursula whisper that she wants to bring a new change of treaties in her next mandate. Let's all put health on there. I think that's also a tool that could help us enormously, because I think the bandwidth we're dealing with, we're talking at a European level here, but it's the 27 member states we got to get them on board through dissemination, and they work at 2, 3, 4 speed Europe. So we've got to think about that. Not suggesting that this is the group that will make Europe responsible for healthcare, but maybe we can have lots of parts to push that forward. Thank you.
Only for a holistic approach of healthcare.
Yes. It's a perfect conclusion, nothing more.
Nothing more. Well, a lot of resources needed still. Please, we move on maybe Unless there's a pressing question from the audience, then maybe the next step